It's a great honor that you have given us the opportunity to present our work with the Esperanza Patient. This talk will be in charge of me, Natalie Laufer, Gabriela Turk, and Dr. Suyu. Gabriela and I work in the University Institute in Buenos Aires, Argentina, and Dr. Suyu in the Reagan Institute in Boston, United States. In this talk, we will just discuss a few aspects about the definitions of elite controllers and post-treatment controllers, what we know about the clinical aspect of the Esperanza patient, and also the laboratory finding that we discovered in her. And after this, we will reach the conclusions, and we have time for discussion. First of all, we will talk about elite controllers and post-treatment controllers. During the natural course of HIV infection, we know that there is a progressive decline in CD40 cells. These cells are key cells of the immune system, so if once they decrease, make the body susceptible to opportunistic infections that take advantage of this immune deficiency to manifest. And also, we know that there is an increased risk of the development of some kind of tumors. And also, these cells are where the virus hides that integrates to the own DNA of the body and persists during time, even during antiretroviral therapy. Nevertheless, there is a subgroup of individuals that behave different from the way that I mentioned before. These individuals that represent less than 0.0% of all the individuals with the HIV have the capacity to control the virus replication, have undetectable viral load. It means when we measure the quantity of virus in the blood, we cannot not found any copy. They preserve the CD4 count. They do not have opportunistic infections. Those individuals have reached what we know as a very good control of the infection. Maybe you have heard many definitions you can see in this slide. There are many ways to define these controllers, what we know or what we understand as HIV elite controllers, and also there are many different degrees of the control of HIV. People who have detectable viral load but at a low level, individuals who maintain good CD4 count. Also, there are individuals who have the opposite behavior and progress very rapidly. So, but if we focus on those individuals who maintain undetectable viral load and who maintain CD4 count and do not have opportunistic infection, we will also be able to see that there are differences among them, and some of them are very exceptional. They have a very good control of the infection, and also what we know as exceptionally controllers can have different definitions, but it's also associated with the possibility to have a very good control not only of the viremia but also of the cells where the virus persists, what we know as HIV reservoirs. Also, we can find what is known as post-treatment controllers. What we are referring with post-treatment controllers. These individuals are people who receive treatment very early during the infection, very early after they acquire the infection, and after a while the treatment is suspended. And once the treatment is interrupted, they maintain with undetectable viral load. This is also a very special population. We have different studies that have described if it's possible to achieve this control after treatment, and we can see that in the different studies, some of them report that none of the patients, none of the individuals achieve this control after antiretroviral interruption, and others have described that they have a 15% of individuals that were able to control the infection after they suspend the antiretroviral therapy. So, with this very summarized presentation about the behaviors that we can find in HIV progression, we can define that there are the chronic progressors, those that without antiretroviral therapy have a decline in CD40 cell count with detectable viral load, and if they are not treated, they have the risk of developing opportunistic infections and death. We have on the other side the elite controllers, those individuals that without treatment can control the replication of the virus, have undetectable viral load, have very good CD4 T cells, and they do not have opportunistic infection. And most of them do not have also this associated manifestation of HIV like cardiovascular disease or bone disease. Most of them do not have it, but some of them can have these associated manifestations. And also we can have these post-treatment controllers individuals, those who have received the treatment very early and after interruption of the antiretroviral therapy can maintain undetectable viral loads. Also, we know that there are two cases that we can refer as they have achieved cure. One is Timothy Brown, we all know as the Berlin patient who unfortunately died 3 years ago, and we also know Adam Castillejos, who is the London patient. Those two individuals, those two men, have an hematological disease, and they need for their treatment a stem cell transplantation. After this transplant that has very particular characteristics, that the donor has a mutation in their DNA that is associated with the lack of one of the co-receptors of the virus, they could suspend antiretroviral therapy and they maintain undetectable viral load, and they also clear all these cells where the virus can remain, the reservoirs. So, why I'm telling you this? Because when we talk about elite controllers, we always make the link with the possibility of HIV cure. So we have this question: if people can control the viremia and can control the infection, is it possible to consider that there is the possibility of a cure HIV infection during the natural infection? Elite controllers seems to be the closest example of this can be achieved, or there is a path or possibility that this can be achieved. And also, with elite controllers, we want to know what are the characteristics that make them, and also with the post-treatment controllers, that can make them have this control of their replication without antiretroviral therapy. So, in this line, the group of Dr. Suyu and Matthias Lichterfeld started to study what happened with people who are on antiretroviral therapy and maintain undetectable viral load for very long times, and with these individuals in elite controllers that maintain the same characteristic but without antiretroviral therapy. As you can see in this slide, when the reservoirs of HIV, it means these CD4 T cells where the virus remain and get integrated to the DNA of the individual, we can see that the total amount of this virus that integrate in the DNA of the individual is much lower in elite controllers than in those individuals with antiretroviral therapy that remains undetectable for very long periods of time. And also, if we specifically look at the intact DNA, it means this virus that not only integrates to the DNA, but also is complete, that has no defects and is able to produce new virus if the cell is reactivated, we can see that the elite controllers also has much lower levels than those individuals on antiretroviral therapy. But specifically, if we look at these two individuals here in the bottom, we can see that they have an even much lower level. And those individuals are the San Francisco patient and the Esperanza patient. The San Francisco patient is Lorraine Willenberg. You know her very well. She has been diagnosed with infection with HIV 25 years ago. She has never received antiretroviral therapy and maintains undetectable viral load without antiretroviral therapy, and she has very good CD4 count and no opportunistic infection. And when I was telling you that she has very low intact, it means she has no intact provirus after examining very large amount of cells that Gabriela is going to tell you how much at the end of this talk. So there was the first clue that maybe it was possible to cure with many mechanisms, but principally it's involved the immune system that can eliminate all these viruses that are able to replicate and can generate new virus without the need of any further intervention. So now we are going to talk about the Esperanza patient that has many similarities with the San Francisco patient. As you know, last year we published our study of the Esperanza patient that has a lot of repercussion in the media, not only in the English media, but also in the Hispanic media and television and newspapers. It gives us the possibility not only to talk about this individual and this case, but also to talk about about the importance of the research regarding HIV, the importance of defeating what is the stigma, the importance of diagnosis, the prompt diagnosis and treatment, and it gives her also the possibility to express what she feels. She, for example, in some of the media, she tell the reporters that just thinking that her condition might help to achieve a cure for the virus make her feel responsibility and commitment to make this a reality, and also that her hope, Esperanza means hope, is that this can be a gate for the cure to everybody. The name Esperanza was given because of her request. She lives and she was born in the Esperanza city. That is a rural city in Argentina. She doesn't want to reveal her name, and that's why I told you before that that give us the opportunity to still talk about the stigma that is related to this infection, because she doesn't feel comfortable to disclosing her positive serology, because she thinks that there are a lot of people who will not understand and probably she will not feel comfortable with them. So now she is 32 years old, but at the age of 23, her ex-partner was diagnosed with HIV infection. At that moment, he has a very high viral load and low CD4 count. He started antiretroviral therapy, but then unfortunately he abandoned the therapy and died in July 2017 due to AIDS-related events. At the moment he was aware about her ex-partner diagnosis, he was tested again because she has a negative serology 2 years before, and the ELISA was positive, and the Western blot has only 3 bands of all the bands that can have, and the physicians on charge of her case told her that it was not possible to confirm or rule out the infection. As you can imagine, that gives her a lot of anguish and anxiety, because from 2013 till 2017, when she get to know us, she was not. She has not a definitive diagnosis. When we get in touch with her, because her physician was the one that requests that if we can follow this very unusual case, but not only because of the characteristic of the serology, but also she has always undetectable viral load, as I will show you in the next slide. So when we first met, I revised all her previous studies, and I told her that by definition she was HIV positive. We can say that she was with HIV infection, because as you probably know, the diagnosis is made by serology, and as we mentioned, there are some individuals that even have a positive serology, have undetectable viral load, that are elite controllers. So after this first visit, it was a shock for her. She has to deal with this new information, with this new diagnosis. It took her a while. It was a long time for us to talk about what it means, what all the consequences, and all the special condition that she has. And when she was able to cope with this diagnosis, she was really willing to help to understand what was happening, and we can say that she's amazing, and really she is really committed with this with finding an answer, with trying to help her and help others to understand if there is a possibility, if there is some way we can find the mechanism that make some individuals to have this very, very special control of the infection that make them elite controllers. As you can see here, she has always had undetectable viral loads. The different shapes means the different threshold of the assays we use each time, and also the very good CD4 count and the very good ratio with CD8 that are very important cells of the immune system. As I mentioned, she had a baby that was born 2 years ago, and she received treatment during the first pregnancy. And she's now pregnant again, and she will receive also antiretroviral therapy, because even we think there is no possibility to transmit the infection to her baby, we have to be absolutely sure and make the risk zero. And that's why, in agreement with her, we decided to give her antiretroviral therapy during the last 2 trimesters of her previous pregnancy, and now we will do it in the last trimester of this pregnancy. And also, she did not breastfeed her baby and will not do it this time, but she is willing that we study her breast milk so we can see if it's safe if it's safe, and with that knowledge to be able to know if other women with undetectable viral load will be allowed or will be able to breastfeed their babies. But this is something that is going on, and it's a study where we are working with her, because she is, as I mentioned before, she is really commitment, and she wants to help to have answers for her and for others. We performed several essays during her follow-up in these years that we know each other. At the beginning, we take blood samples from peripheral blood. Then we study her placenta. It was like something extraordinary to be able to get to the placenta, because it was the beginning of the lockdown in our country because of COVID, and her family was really helpful bring the placenta from her city to Buenos Aires, where we work. Then during the first year of the COVID pandemic, we were able to perform a leukapheresis to be able to have a lot of samples to study if the virus was integrated on those samples or not, and if it was integrated, what were the characteristics of these samples. Her partner, now he is HIV negative and remains HIV negative. We have performed a new serology last week. Now Gabriela is going to tell you about what we found in the laboratory and the different assays that we performed with the samples I have mentioned you in the previous slide.
Hello everybody, my name is Gabriela Turk, and as Natalia mentioned, I will be presenting our laboratory findings in the Esperanza patients. So to evaluate persistent HIV reservoir cells in this person, we first use conventional PCR-based methods to detect DNA and RNA HIV forms in a regular number of cells. For this, we use cells obtained in 2017. That was the year we first met her, and this is the first sample we obtained from her. So using these conventional techniques, no signs of HIV-infected cells were detected. As you can see here in the table, all results were 0. Also, we evaluated low-level viral load in an ultrasensitive assays, and no RNA copies were detected, at least in 4.5 mL of plasma, such confirming again that she was an elite controller, but she was a very special case of an elite controller. So next, we use the technique called flip assay, which is near full-length individual proviral sequencing for single genome amplification of HIV DNA. This technique allows to identify single infected cells and obtain the viral full sequencing in those cells. For this, we use several samples obtained at different time points. In the graph in the right, you can see in red all the numbers of cells obtained at the different times where samples were obtained in 2017, 2018, 2019, and 2020. All cases correspond to peripheral blood cells, except for the sample obtained in March 2020, which correspond to lymphocytes obtained from placenta. In brackets, you can see the number of sequences obtained in samples from each time point. You see here 3 in the samples of 2018, 1 in 2019, and 3 in 2020. All of these samples were retrieved from cells obtained from peripheral blood, and non-viral sequence was obtained from cells obtained from placenta. So a total of 7 proviral HIV DNA copies were detected in a total of 1.18 billion PBMCs. So sequence analysis of these viral copies indicated that all 7 copies, you can see here, were defective. That is, one of them was hypermutated, while the remaining 6 sequences had large deletions. 4 of these sequences were different among them, and 3 of them, here in this square, were clonal. That means that they were almost identical. So this result particularly confirmed that this person was once infected with HIV, and that active cycles of viral replication had occurred at least at one point. So also in these tables there is a summary of the results, and you can also see here additional assays such as the QBOA assay, that is the viral outgrowth assay, was performed in 150 million CD4 cells, and here again no replication competent virus was found. In order to exclude defects in the patient's cells that could explain her particular phenotype, expression of viral core receptors were studied in her cells, and as you can see in this graph, both CXCR4 and CCR5 molecules were readily detected in her cells. Also, activated CD4 cells could be infected in vitro. This is, her cells support HIV replication, at least in vitro. And finally, HLA genotype performed in this in samples, of course, of this patient showed that none of her HLA alleles were particularly associated with HIV control. So all these results also confirm that she has no genotype or phenotype that makes her particularly resistant to the infection. Finally, HIV-specific cellular immune responses were evaluated in the sample obtained in 2020. A very low level, albeit detectable, proportion of P24-specific CD4 and CD8 T cells were detected in this sample, showing that a memory response to this antigen is present in her body. So overall, here we describe the Esperanza patient, who is a person who displays the clinical phenotype of an HIV elite controller, but she is even more exceptional based on the absence of detectable intact HIV proviruses or replication competent particles after analyzing a large number of cells. So she resembles the San Francisco patient, or Lorraine Willenberg, as we all know her, who is indeed the first person described so far who might have achieved a natural cure of HIV infection. And in turn, both of them resemble at this point the case of Timothy Brown or the Berlin patient. So, which is the take-home message after all this? Well, we can say that the Esperanza patient and as well as the San Francisco patient are elite controllers in where we fail to detect any intact or replication competent provirus, despite having done a comprehensive analysis of a massive number of cells and multiple complementary virologic assays. What does it all mean? That we were unable to find any copy of virus that could be a source or a new source of a detectable viral load. Does it mean that she's cured? Well, certainly she was once infected, and now we can say, as I said before, that we were unable to find any intact virus after analyzing a huge amount of cells, but we can't confirm by 100% that she's cured. So long-term follow-up will provide additional proof in this regard. And also the other $1 million question is, which was the underlying mechanism that allowed her to reach her and also the San Francisco patient this so special status? Well, we can't tell either. However, we think that very early after infection, rounds of autologous shock and kill or poke and clear processes occurred in the body naturally, and this resulted in the elimination of cells having intact proviruses, and only cells with defective proviruses persisted in the body, and this is what we are seeing with the assays nowadays. So to finish, exceptional cases are as those described here, of course, enhance our knowledge on how the virus behaves and how the body responds to the infection. I'm sure that in the future we can expect a cumulative number of similar cases that of course boost and motivate HIV cure research field, and for sure will provide more data to help fight this infection. So thank you very much. Once again, we are very grateful for the invitation to participate in this meeting. And now, of course, we are open to questions and discussion. Thank you.
All right. And so we had a few questions come up. I know Dr. Xu Yu is on the line here, and I also see Gabriela, so I'm going to pin you. Wonderful. This is amazing. But what are people supposed to make of all of this? I mean, you see all these headlines, and if you live with HIV, you might just feel sort of left out. They're two special people, and it's great to know, but why should I care about either of these? And if you want to unmute either one.
Yes, I will start. Okay, so hello, good morning, good evening, and good afternoon, everybody. And yes, as Michael said, they are, of course, unique cases. As I said in the last slide of this presentation, it's probably that more cases will be described in the future as them. So what we can expect of all of this is that certainly it's very unusual, but certain mechanisms of the immune response can clear in the long term infected cells in the body. So it is like an initial clue, and it's like a small opening in a window that we can look through and expect in the future to have more results and more data that help describe similar cases, find cases, and one of the questions was mentioning in the chat of maybe some elite controllers or very good controllers that are currently under IRT that can possibly stop their treatment, of course with the proper guidance, and maybe of course also describe other elite controllers that are similar to Lorraine or the Esperanza Patient.
Hi, I'm sorry, I don't have my camera on because
That's okay.
I am in a... Hi, do you listen to me?
Yes, yes, so we can hear you. Go ahead.
Yeah, yes, because I am in a place with very bad connection. Yeah, as Gabriela says, it's also the possibility to think that we can think about HIV cure without a stem cell transplantation. Maybe there are some other strategies that are not dependent on this very hard medical intervention that is the stem cell transplantation, as you know. So I think that the message is that it opens, as she says, the window that there is a possibility to think that the cure is something that we can achieve. And also, as you mentioned in the chat, that there are some elite controllers that maybe they are not cured. They are not cured, but they control the infection so well that they may not need antiretroviral therapy, because now there is all this tendency to treat everybody. I think there are many of them that they need treatment because they have other activation issues and immune senescence, but some of them they maybe not need this treatment, and they also will allow us to know if there is anything, what is in their immune system that allow them to have this very, very extreme control of the infection.
Wow. So, Dr. Xu, I wanted to ask specifically, but what about the maybe potentially similar findings that we might find in people who are on long-term ART?
Yes, that's definitely a really important direction we are going. Overall elite controllers is only represent about 0.5% or even less of all HIV people living with HIV, and so our attention now is really towards to how do we characterize and better inform the people who have been on ART for many years, even though their immune system may not be as strong as elite controllers, but over time they are still working very hard to try to eliminate the potentially functional virus in our body. So the recent publication early this year in Cell, indicating that after 2 decades of treatment, especially seems the second decade of treatment has been impacted much more, to allow the immune system to work much better, that a subset of long-term ART treated individual have already achieved a reservoir profile very much look like what elite controller naturally gained in very short time after their infection. So the big question is really, would it be possible any of them stop treatment would actually maintain an elite control status as the natural elite controllers? I would definitely caution anyone don't stop treatment without knowing exactly what the reservoir profile, where the virus hitting, how effective your body immune responses already hit these virus, how hard they were hit before taking off treatment. But even if you treat off treatment, should be really under supervision, under extensive evaluation. We actually proposed a similar study to do treatment interruption, but under weekly or even more frequent kind of a monitoring. But we are hopeful that could be a way that in the future that we do not everybody on lifelong ART, hopefully.
Right. So that reservoir test, that profile you were talking about, that's not something that's normally done in clinical care. So
No.
That would be something through a research study, the only way really to determine if your reservoir was this type of profile and would be able to go ahead with that.
Exactly. But I also see a kind of a question in the comments is like, how do we increase women participants in all sort of clinical trials? And this is really promising. We see 2 extreme exceptional elite controllers are women, and we do see in our the long-term ART treated cohorts, the women participants also doing extremely well. Their reservoir is really looking very, very promising. So we are aiming for recruiting for future studies 50% of women. That's what we are under discussion with IMFAR to really promote inclusion of women into these long-term ART treatment studies.
And do we have any reason why this might be happening in women?
We don't know. I mean, if we know why, that's probably really the answer to which direction of the immune system, the immune responses we want it to go, right? I mean, we know women usually suffering from more immune activation, more kind of autoimmune problems, and maybe at one point that be good. You know, you hit the viral infected cells stronger. So we don't know. We are looking into it, but it is possible that's hold as well a resolution for the mist that we are trying to understand.
Well, that's wonderful. And I know Andy asked a question, this could be for either of you, wanting to know if the Esperanza patients' levels of inflammation were similar to people who are HIV negative, or what's the inflammation situation in her case?
Well, we don't have much of that data about inflammation in her and regarding immune activation. This is something that we are planning to do in the future. Now she's pregnant again, so she won't be giving us any more samples for a few months. But after that, it's something that we plan to do. And I would like to add something to the comments that were done before, because sometimes many people ask me, well, why these kind of special cases or unique cases are being described now, and we never heard about this kind of cure cases before. Well, we are allowed to say this now because of new technology. Of course, we have new technology, new methods. We improved a lot during the last maybe 10 years in molecular assays, sequencing assays. So this is giving us the opportunity, and again, a new window to generate more data.
Well, thank you for that. This is such a fascinating topic, and I'm sure we could go on, but we are kind of over time. So we're going to move on to our last session. But I want to thank you both for all three of you, actually, even though I think Natalia might have left us. But thank you all for taking the time, sharing with us this news. And I'm sure if people have any follow-up questions they want to ask, please, we can send them. We'll forward them to the doctors here, and we'll be able to get your questions. But fabulous job. Thank you very much for such a thorough exploration of the Esperanza patients.
Thank you very much again for the invitation.
Yes, you're welcome.